Assalamu alaikum. Welcome to our today's session. We will discuss today on approach to management of movement disorder. Every neurologist think this is the toughest topics of neurology. So we will try our best to simplify these topics so that it will be helpful in our chamber practice and also at the exams also. So we can start. Actually, movement disorders are clinical syndromes which there is excess of movement or there may be less movement, which may be voluntary or involuntary, which all are included in the movement disorder. The movement disorder may be primary movement disorder, or the abnormality only is the abnormal movement. Movement disorder may be secondary movement disorders, where the abnormal movement is associated with other neurological or systemic disorders. Movement disorders are classified broadly: hypokinetic movement disorder, or you can call it bradykinetic movement disorder, and hyperkinetic movement disorder. The prototype of hypokinetic or bradykinetic movement disorder is Parkinsonism. You all know about Parkinsonism, and lots of world famous persons suffered from Parkinson disease and also Parkinsonism. This is the pictures of Muhammad Ali, who has been suffering from long time from this Parkinson disease. And another movement disorder is hyperkinetic, that's opposite of hypokinetic. And examples are lots of examples in hyperkinetic group like tremor, chorea, athetosis, bellismus, especially we can call it hemibellismus, dystonia, myoclonus, akathisia, and tardive dyskinesia. This also can be included into dystonia. So these are the common hyperkinetic movement disorders, and hypo or bradykinetic movement disorder is Parkinson disease, Parkinson plus secondary Parkinsonism, and another example is catatonia. It's on type of schizophrenia, which is called catatonic schizophrenia. There is also bradykinetic movement there, so it is under the headings of bradykinetic or hypokinetic movement disorder. We all know the site of involvement in movement disorder is basal ganglia, but not only the basal ganglia, other parts of the brain are also involved in movement disorders, which may be cerebellum or its connection, cerebral cortex, thalamus, even any part of brainstem, including midbrain. You all know that is the rubral tumor or Holmes tumor, spinal cord, sometimes spinal myoclonus is there. This is also a movement disorder, where the involved site is spinal cord. Sometimes peripheral nerve involvement can cause also movement disorders. So these are the site where movement disorders is responsible. This is a brain showing, this is the caudate nucleus head, this is the internal capsule, this is the anterior limb, this is the genu, this is the posterior limb, this is the thalamus, and this is the lentiform nucleus, which is divided into internally the globus pallidus and laterally by the putamen. And globus pallidus itself is divided into globus pallidus interna and globus pallidus externa. The caudate nucleus and the putamen combinedly act, একসাথে কাজ করে, so they are termed as stratum. They can be termed as stratum. This is a coronal section, also showing this deeper structures of the brain. And this is the C-shaped caudate nucleus. C-shaped caudate nucleus. This is the C-shaped caudate nucleus. And this is the putamen. And this caudate nucleus and putamens combinedly connected to the nigral, striatonigral by the striatonigral pathway to the midbrain, and this both acts conjointly. So these are the pathways of main pathways of movement disorder. Before we started to movement disorder, we should have a basic idea of this movement disorder. আমরা যদি এটাকে একটা স্কেমেটিক ভিউতে দেখি, cortex, striatum, that means both caudate nucleus and putamen. This is a subthalamic nucleus, globus pallidus externa, globus pallidus interna, and substantia nigra pars reticularis. Substantia nigra pars compacta is the region of the midbrain responsible for productions of dopamine, and this pars reticularis is not responsible for dopamine. And this is the thalamic nucleus, and this is the cortex. So this is the circuit responsible for movement disorder. আমাদেরকে এই সার্কিটটা খুব ভালোভাবে জানতে হবে. We should have clear idea about this circuit. And there's some neurotransmitters related to this circuit. This is glutamate. We know all. It's an excitatory neurotransmitter. This is GABA. We know it's a inhibitory neurotransmitter. This is a normal brain. There is no abnormal movement. This is a normal brain. We all know cortex থেকে stimulus goes to striatum, and it stimulates the striatum by glutamate, double stimulation, and there is a productions of dopamine from substantia nigra pars compacta. It has two receptors, D1 receptor and D2 receptor. D1 receptor is called a direct pathway. Directly it connected to the globus pallidus interna and substantia nigra pars reticularis. যখন কর্টেক্স স্ট্র্যাটামকে স্টিমুলেট করবে, এইখান থেকে ডোপামিন উইল স্টিমুলেট দিস D1 রিসেপ্টর. আমরা একটা পাথওয়েটা ভালো জানবো, D2 পাথওয়ে ঠিক তার উল্টা. সো একটা জানলে আমরা আরেকটা বুঝতে পারবো. So this D1 receptor then released GABA. We all know this GABA is a inhibitor neurotransmitter, and it inhibits the globus pallidus interna and substantia nigra pars reticularis. And এখান থেকে GABA প্রোডাকশন হয়. GABA প্রোডাকশন হওয়ার ফলে যখনই এইটা বেশি ইনহিবিটেড হবে, সো এখান থেকে GABA প্রোডাকশনটা কম থাকবে. GABA প্রোডাকশন কম থাকলে এইটা তখন এইটা এই থ্যালামাসকে অত বেশি ইনহিবিট করতে পারবে না. ফলে এখান থেকে গ্লুটামেট প্রোডাকশন হবে এবং নর্মালি মুভমেন্ট হবে. D2 পাথওয়ে ঠিক তো উল্টাভাবে কাজটা করে. তবে একে ইনডিরেক্ট পাথওয়ে বলা হয়, কারণ এটা গ্লোবাস প্যালিডাস এক্সটার্নাল মাধ্যমে পরে সাবথ্যালামিক নিউক্লিয়াসে আসে, সেখান থেকে পরবর্তীতে সে জিপিআইতে চলে আসে, এবং সাবথ্যালামিক নিউক্লিয়াস কিন্তু এখান থেকে গ্লুটামেট রিলিজ হয়. অল দ্য ইন্টারনাল স্ট্রাকচার খেয়াল করে দেখবেন, there is GABA, that is inhibitory neurotransmitter, except subthalamic nucleus. But cortical, there is a glutamate, যে থ্যালামাস থেকে কর্টেক্সে আসে, কর্টেক্স থেকে স্ট্র্যাটামে আসে, সব আর all are excitatory neurotransmitter, but internal structure all the neurotransmitters are inhibitory neurotransmitter. So in case of Parkinson disease, that is hypokinetic movement disorder, what happens? We all know in hypokinetic disorder like Parkinson disease, there is depletion of the substantia nigra pars compacta, so reduce productions of the dopamine. Dopamine productionটা কম হবে, ফলে এটা ডিওন রিসেপ্টরকে কম স্টিমুলেট করবে। ডিওন রিসেপ্টরকে কম স্টিমুলেট করলে কি হবে, এই গাবাটা এখান থেকে কম পরিমাণে প্রোডাকশন হবে। সুতরাং এই জিপিআই বা এসএনআর গ্লোবাল স্পাইডাসটা কিন্তু কম ইনহিবিটেড হবে, কম ইনহিবিটেড হবে। কম ইনহিবিটেড হলে এখান থেকে গাবা কিন্তু অনেক বেশি পরিমাণে প্রোডাকশন হবে, গাপা বেশি প্রোডাকশন হবে, ফলে এটাকে সে অনেক বেশি ইনহিবিট করবে। ইনহিবিট করার কারণে গ্লুটামেটটা যেতে পারবে না কর্টেক্সে, গ্লুটামেটটা কর্টেক্সকে স্টিমুলেট করতে পারবে না, তখনই কিন্তু ইনহিবিটেড মুভমেন্টটা হবে। দিস ইজ দ্য বেসিক প্যাথোজেনেসিস, আন্ডারলাইং প্যাথোফিজিওলজি in any type of bradykinetic disorder, especially Parkinson disease. It works by this direct pathway. At the same time, indirect pathway তে কি হয়? ডাইরেক্ট পাথওয়েতে আমরা আগে দেখছিলাম যে ইনডাইরেক্ট পাথওয়েতে কি হয়, ডোপামিন এটাকে ইনহিবিট করে অনেক বেশি। এটাকে এখন যদি ডোপামিন প্রোডাকশন কম হয়, এই D2 তে ইনহিবিশনটা কমে যাচ্ছে। আগে যেমন ডবল প্লাস ছিল, now in case of Parkinson disease it is 1 plus, so there is less inhibitions of the D2, so D2 থেকে গাবাটাও আগে দেখেন যতটুক যাচ্ছিল, এখন যেহেতু ইনহিবিশনটা কম হচ্ছে, সো গাবার পরিমাণ এখান থেকে আরো বেশি হয়ে যাবে, কারণ এটা ইনহিবিশনটা কম হচ্ছে। এবং এখান থেকেও গাবা ইনহিবিশনটা যখন গ্লোবাসপাস এক্সটার্নাতে যাবে, এখানে দেখুন গাবা প্রোডাকশনটা আগের তুলনায় কমে যাবে, কারণ এই ইনহিবিশনটা এখন বেশি হচ্ছে। সো যখনই এখান থেকে সাবথ্যালামিক নিউক্লিয়াসে যাবে, আগে দেখুন সাবথ্যালামিক নিউক্লিয়াসকে সে ডবল ইনহিবিশন করতেছিল, এখন ইনহিবিশনের মাত্রাটা কমে যাবে। মাত্রা কমে গেলে সে গ্লুটামেট প্রোডাকশনটা অনেক বাড়িয়ে দিবে। আগে যেমন গ্লুটামেট প্রোডাকশন ছিল ডবল প্লাস, এখন গ্লুটামেট প্রোডাকশন ট্রিপল প্লাস হয়ে যাবে, এবং এটাকে সে স্টিমুলেট করবে। যখনই এটাকে স্টিমুলেট করবে তখনই কিন্তু গাবা প্রোডাকশনটা এখান থেকে বেশি প্রোডাকশন হবে। তাহলে আমরা দেখতে পাচ্ছি যে সাবথ্যালামিক নিউক্লিয়াসকে যদি আমি স্টিমুলেট করতে পারি বাই এনি হাউ, এখান থেকে গ্লুটামেট প্রোডাকশনটা বেশি হয়ে যাবে এবং জিপি1 কে সে স্টিমুলেট করবে। আর ডাইরেক্ট পাথওয়েতে জিপিআই কে কম ইনহিবিশন হবে। কম ইনহিবিশন হওয়া আর স্টিমুলেটেড হওয়া দুইটা কম্বাইন ইফেক্টলি এখান থেকে দেখা যায় গাবা প্রোডাকশন অনেক বেশি হয়ে যাবে, থ্যালামাসকে টোটালি সে সাপ্রেস করে দিবে, থ্যালামাস থেকে নো গ্লুটামেট এন্ড দেয়ার উইল বি ব্রাডিকাইনেটিক মুভমেন্ট ডিসঅর্ডার। যদি পেশেন্টের হাইপারকাইনেটিক ডিসঅর্ডার হয় এবং ইজ এ প্রোটোটাইপ অফ হেমিবেলিসমাস বা ডিসকাইনেসিয়া, সেক্ষেত্রে কি ঘটনা ঘটবে? সেক্ষেত্রে কি হবে? সেক্ষেত্রে there is a lesions in the subthalamic nucleus. সাবথ্যালামিক নিউক্লিয়াসটা যখন কাজ করবে না তখন এখান থেকে গ্লুটামেট প্রোডাকশনটা কমে যাবে। গ্লুটামেট প্রোডাকশন কমে গেলে এখান থেকে যে এটাকে এর স্টিমুলেশনটা কম হবে, ফলে এখান থেকে গাবা পোর্শনটাও কমে যাবে। গাবা যখন এখানে কমে যাবে তখন থ্যালামাসটা কিন্তু আনইনহিবিটেড হয়ে যাবে। When the thalamus is uninhibited, it will produce more glutamate, it will stimulate the cortex, and there is the exertion of the movement. This is the basic pathophysiology. So আমাদের এখানে মেইন কথা হলো হাইপোকাইনেটিক ডিসঅর্ডারে আমাদের সাবথ্যালামিক নিউক্লিয়াসটাকে স্টিমুলেট করতে হবে এবং ডিওন রিসেপ্টরকে ইনহিবিট করতে হবে, তাহলে সেক্ষেত্রে আমাদের ব্র্যাডিকাইনেসিয়া হবে। আর ইন কেস অফ হেমিবেলিসমাস or hyperkinetic disorder, subthalamic nucleus is inhibited, so there is less productions of glutamate, there is less stimulations of the globus pars interna, so less production of GABA and less inhibitions of the thalamus, so more productions of the glutamate, and this vicious cycle is going on and on. দিস অল আর দ্য মুভমেন্ট ডিসঅর্ডার, আমরা এটা লাস্টে আমরা দেখব। সো আমরা প্রথমত সবচেয়ে মোস্ট কমন মুভমেন্ট ডিসঅর্ডার hyperkinetics, that is tremor. We will discuss about tremor. Tremor is a oscillatory movement, oscillatory rhythmic movement. Tremor is a oscillatory rhythmic movement of a body part due to intermittent muscle contraction of both agonist and antagonist. It's a rhythmic oscillations of a body part due to alternating contractions of the agonist and antagonist. It is called tremor. It's a rhythmic movement. It may be postural tremor, that may be tremor when the hand is outstretched. The tremor may be at the resting state, and tremor may be at actions due to either কোনো একটা কিছু জিনিস ধরার জন্য বা কোনো একটা কাজ করতে গেলে যখন ট্রেমর হয়, at the টার্গেট পয়েন্টে যখন ট্রেমরটা হয় তখনকে সেটাকে আমরা অ্যাকশন ট্রেমর বা অনেকে এটাকে ইন্টেনশন ট্রেমর বলে। ইফ দ্য ট্রেমর occurs just at the target point, not at the beginning but at the target point, that is called action tremor or intention tremor. When the tremor occurs at the beginning of the movement or at the outstretched hand but not at the wrist, it is called postural tremor. The most common cause of postural tremor is the physiological tremor, drug induced tremor like caffeine and nicotine induced. If alcohol is withdrawn, increased metabolism due to any cause, and the most common postural tremor is the essential tremor. This essential tremor can be a postural tremor, can be a action tremor. So this আমি এখানে এই জন্য এরকম ক্রসিং দেখি, there is some overlapping also, but this is the most common cause of this type of tremor. Resting tremor, the prototype is the Parkinsonism, that is Parkinson disease, drug-induced Parkinsonism, or Parkinson plus, but not the Parkinson disease not only present as resting tremor, but it can present also as postural tremor or even action tremor. And the most common cause of action or intention tremor is the cerebral lesion, either due to stroke or any mass in the cerebellum, maybe multiple sclerosis involving the cerebellum, or chronic alcohol abuse. This can also cause intention or action tremor. First of all, we will discuss about the essential tremor, the most common of all movement disorder, not only the tremor, but all movement disorder. The most common tremor is the essential tremor. The essential tremor usually is symmetric, but it may be asymmetric, and it is postural tremor, but sometimes it is action tremor. Patients with essential tremor complaining of difficulty during eating, even handwriting, shaving, or any other normal household works, but they can do their works with this essential tremor without significant difficulties. The most common sites of essential tremor is the hands. 95% cases there should be hand involvement. Head involvement is also important in essential tremor, either ESS or no movement, and voice tremor. There is difficulty in speech. There is difficulty during speech, voice tremor there. These essential tremors are autosomal dominant. That means there should be a family history. There should be a family history, and it is treated or improves briefly with alcohol. This is the tremor. Sometimes some Western country people who has been suffering from this essential tremor, they very usually uses this alcohol not only for treatment but also as a as they use this regularly. So it lessens their essential tremor. Essential tremor usually mild course and prolonged course, and drug of choice is either primidone or propanolol or both. We use mostly the propanolol, the most available drugs, if not contraindicated, like bronchial asthma or peripheral vascular disease. But primidone is a very good drug It's the oldest drug. It uses as anti-epileptic drugs, but it can be used in essential tremor with very good effect. And sometimes we may need the combinations of primidone and propranolol. If all the drugs failed and this tremor hampers daily activities very significantly, we should go for deep brain stimulation. We should go for deep brain stimulation. How it's very difficult, sometimes it's very difficult in your chamber or in your private, in your practice or in your exam. Either it is an essential tremor or a tremor from Parkinsonism. দেখা গেছে যে 20% থেকে 30% ক্ষেত্রে আপনি একটা পেশেন্টকে ইনিশিয়ালি ডায়াগনোসিস করলেন ইটস এসেনশিয়াল ট্রেমর, বাট in the long term, after a few weeks, after a few months or few years, it actually it was a Parkinsonian tremor. So it sometimes is very difficult to differentiate clinically from essential tremor from Parkinsonian tremor. But in case of Parkinsonism, the tremor usually asymmetric at onset and usually resting tremor. But in case of essential tremor, it is usually symmetrical and not at the rest. It usually occurs at the postural change, at the posture, at also walking or also during action. Tremor that occurs during walking usually suggests an underlying diagnosis of PD. Patients with essential tremor, there should be no prominent extrapyramidal sign like rigidity, the cog wheel or rigidity or lead pipe rigidity or postural disturbance. 50% of essential tremor patients responds very well with alcohol. We previously discussed. A no-no or ESS head tremor is very diagnostic of essential tremor, but rarely occur in Parkinsonian tremor. But jaw tremor, if the involvement in the jaw, the temporomandibular joint involvement, there is a tremor in the TM joints, it is more pathognomic of Parkinsonian tremor. But if the tremor involves the head and there is ESS or no-no movement, it's more likely essential tremor. Handwriting is also hampered in both cases. But in case of PD, the handwriting is small and illegible. But in case of ET, essential tremor, it is large and tremulous, and it is small. এটা দেখা যাচ্ছে প্রথমে ছোট ছোট হতে হতে আরো ছোট হতে থাকে এবং বোঝাই যায় না। আর in case of essential tremor, it is large, অনেক বড় হতে থাকে, and tremulous. Usually, in case of essential tremor, there should be a voice tremor. In associated voice tremor also is in case of essential tremor. So we can differentiate it when a voice tremor is present, it is more likely essential tremor. We can see a video on tremor.
Welcome to a Stanford Medicine 25 video on the approach to tremor. The goal of this video is to help you figure out what's causing your patient's tremor. Let's start by reviewing the different categories of tremor. The postural tremor is easy to find by asking your patient to hold their arms out. Causes include a normal physiologic tremor, which can be increased in certain states such as sleep deprivation, too much caffeine or nicotine, alcohol withdrawal, increased metabolic states such as in hyperthyroidism, and essential tremor. This is an actual patient from Stanford Hospital with a history of familial essential tremor. As you can see here, with his arms straight out, held up in the air, the tremor is persistent, as seen by the creeping in the air. Patients with essential tremor will oftentimes have a shakiness in their voice as well. If you listen really closely, you can hear slight variation in this patient's voice. The resting tremor is simply examined at rest. Causes include Parkinson's disease, drug-induced Parkinsonism, and less common supranuclear palsy. Here's a resting tremor in a patient with severe Parkinson's disease. If you look closely, even his left leg has a tremor at rest. A tremor is also seen in this patient's face from the same disease.
This is jaw tremor. This is a jaw tremor.
The third and final category of tremor is the action tremor, sometimes referred to as the kinetic, or for our purposes, the intention tremor, which occurs in essentially any type of movement. Causes include cerebellar lesions, like a stroke or a cerebellar mass, multiple sclerosis involving the cerebellum, or chronic alcohol abuse. And here's our patient with essential tremor demonstrating a normal finger to nose exam. As you can see, the patient is being asked to pick multiple areas to reach his finger out and extend it almost fully. One last thing to mention, sometimes many of these causes of tremor.
These are also examples of a patient with essential tremor. There is no tremor at the wrist, no tremor at rest. Patient has a positive family history of tremor, but when the hand is outstretched, there is a tremor. This is a postural tremor, and it's a bilateral symmetrical hand tremor. This is essential tremor. So, with essential tremor, patient can do his normal activities, like this patient.
With my right hand, things were difficult, but now I can just prop that right up. I have had essential tremor since I'm a teenager. When it first started, very, very mild. As time went by, my left hand was worse than my right hand, and I know, but the last few years were very embarrassing. I couldn't write a letter or sign my name. Cooking was very difficult, cutting or slicing. Whatever I had to do would take me 3 or 4 times longer. I would hold my left hand with my right hand to try to put my makeup on. Then I'd get in the car and there would be the mirror, and I looked like a clown wiping some of the makeup off that I didn't see in the mirror. In some ways, this does take your independence away from you.
So, that's all about tremor. Now we will go for dystonia. The dystonia. It's actually a movement disorder characterized by sustained or intermittent muscle contractions that cause abnormal, often repetitive movements, posture, or both. This is a type of movement disorder where there is a uh, simultaneous contractions of both agonist and antagonist. একই সাথে প্রত্যেকটা জয়েন্টের অ্যাগোনিস্ট এবং অ্যান্টাগনিস্ট যখন একই সাথে কাজ করে তখন there is a twisting or there is a change of posture of that joint, and at the same time there may be some tremulous movement, and this is called dystonic tremor. The dystonia is often initiated or worsened by voluntary action and associated with overflow muscle activations. Dystonia actually is divided into 4 categories. It may be either due to primary, that is idiopathic. It may be dystonia, may be some secondary cause of dystonia. There may be some genetic cause of dystonia. The most common form of idiopathic dystonia is blepharospasm, that is spasmodic contractions of the eyelids. Cervical dystonia, that is called torticollis. Spasmodic dysphonia, there is involvement of the vocalis muscles involvement, and there is a voice tremor. This is called dystonia of spasmodic dysphonia. Sometimes it is needed conjointly by both ENT specialist and neurologist to treat this type of spasmodic dysphonia, as it is needed the botulinum toxin injections into the vocalis muscles. And another is a very common issue, that is writer's cramps and other task-specific dystonia. অনেক সময় দেখবেন যে অনেক পেশেন্ট কমপ্লেন করে যে যখন সে পরীক্ষাতে লিখতে যায়, when he or she tries to write in the exam or any other else, কিছুক্ষণ লেখার পরে after sometimes there's cramping pain over his hand. This is called writer's cramp. অনেক সময় মিউজিশিয়ান ক্রাম্পস বলে, মিউজিশিয়ানস ডিস্টোনিয়া, যারা মিউজিক করে তাদের দেখা যাচ্ছে যে ফার্স্ট দুইটা আঙুলে এই ধরনের স্পাজমোডিক পেইন হতে পারে, মিউজিশিয়ানস dystonia. These are the task specific dystonia. So these are the most common idiopathic dystonia. How can we evaluate a dystonia clinically? We have to go for two axes. Axis on regarding clinical manifestations. Age of onset is very important. Is it started infancy, childhood, adolescence, early adulthood, later adulthood? So depending on the age of onset, the causes are different. Which site of the body is involved? Either it is focal, just a one group of muscles are involved, or segmental. That means segmental means একটা মাসেল এবং তার অ্যাসোসিয়েটেড এরিয়া হতে পারে, একটা নেকের একটা মাসেল সাথে হ্যান্ড শোল্ডার জয়েন্টস, দিস কল সেগমেন্টাল। মাল্টিফোকাল, যখন মাল্টিপল জায়গায় ইনভলভমেন্ট হবে, মাল্টিপল জায়গায় সেপারেটেড, মাল্টিফোকাল। জেনারেলাইজ যখন হোল বডিতে ইনভলভমেন্ট থাকবে, দুই পাশে বায়োলেটারাল সিমেট্রিক্যাল, দ্যাট ইজ কল্ড জেনারেলাইজড। This can also help to identify the underlying cause, and it can also help in management purpose also. So body distribution is very important. Temporal features, overall course, how many days it occurs, short-term variation, is there any variation? Associated features is very important. Sometimes dystonia is purely dystonia, no other clinical manifestations, but sometimes dystonia is associated with other clinical manifestations. So this will help to identify the underlying causes. To know the underlying etiology, it may be no pathology there, degenerative pathology, some static lesions may be present. It may be inherited in the form of idiopathic inherited, acquired, or sometimes inherited. Idiopathic, acquired, or sometimes some lots of dystonias inherited. We will not go details of these classifications of dystonia. How will you manage by dystonia? Manage the dystonia. Dystonia is managed by three ways. Number one, some oral medications. Number two, botulinum toxin. Number three, the deep brain stimulation surgery. Oral medications, especially for generalized dystonia, but for focal or segmental dystonia, the first line treatment should be botulinum toxin and the second line should be drugs. But for generalized dystonia, the first line should be the oral medications, the second line may be botulinum toxin. So drugs available for dystonia are trihexyphenidyl, any type of dystonia. Levodopa or carbidopa can be used in some dystonia which is at childhood onset dystonia, which is called the dopa responsive dystonia. There is a very, if the dystonia occurs, যদি একটা dystonia খুব early childhood এ develop করে, আমরা তখন তাদেরকে এই লিভোডোপা চ্যালেঞ্জ দিয়ে দেখি পেশেন্ট রেসপন্স করে কিনা। কারণ কিছু কিছু ইনহেরিটেড বা জেনেটিক ডিস্টোনিয়া আছে যেগুলো চাইল্ডহুডে স্টার্ট হয় and they are responsive to levodopa carbidopa. Dystonia can be treated by tetrabenazine. The most common dystonia treated by tetrabenazine is tardive dystonia and oromandibular dystonia. Usually we start with half of 25 milligram tablet and increase by half to one tablet every 2 to 7 days to maximum even 100 milligram per day in 3 to 4 divided doses. Sometimes we can use clonazepam for any type of dystonia, especially generalized dystonia, and baclofen, any type of dystonia. It may be as a add-on therapy with other drugs. Botulinum toxins is a first-line drug for focal and segmental dystonia. And this botulinum toxin usually remain active for 3 to 6 months. Sometimes patients may need multiple shots. And when these dystonias are intractable to either botulinum toxin or oral medications, we can go for DBS, deep brain stimulations, for this type of dystonia. This is a patient presented to me with there is a segmental dystonia with dystonic tremor. There is a torticollis, there is neck dystonia involving the shoulder joints, and also there is tremulous movements of his hand. This is a segmental dystonia with dystonic tremor. This is a dystonic tremor. There is a so this is dystonia, focal segmental dystonia with dystonic tremor. This patient also presented to me with hemifacial spasm. This is also a dystonia, hemifacial spasm. Patient has previous history of Bell's palsy, followed by this type of abnormal movement over his left side of his face, including his uh, eyelids, that is blepharospasm. This patient presented to me with difficulty in talking. This is lingual dystonia. Actually, this patient suffering from orolingual dystonia. Orolingual dystonia, not only the lingual dystonia, but also orolingual dystonia. So here the best or first line treatment is botulinum toxin. This patient presented to me with bilateral blepharospasm. There is difficulty in opening of his both eyes. This is called bilateral blepharospasm, and the cause is also idiopathic. It is the underlying cause is not found, and I gave him botulinum toxin, and patient is now completely normal. He could not open his eyes for a long time. So we can go for some other movement disorders. The video.
In this video, we'll talk about the terminology of movement disorders. Starting with coordination. This is a sudden, strong, jerk-like movement that can be best described as someone throwing something. We see this in basal ganglion disorders and Huntington syndrome. Next, we have myoclonus, and this is a sharp, sudden, weak movement. It's almost like a shock or sudden vibration in a muscle. And this can present as hiccup. We see this in hepatorenal syndrome. Next, we have dystonia, which is a sudden contraction in a muscle and sustained of that contraction. This commonly presents in the hand as writer's hand when the eyelids, with constantly closed or open eyes. Next, we have apoptosis.
There is a
This is a
slow
small,
breathing movement of the hand, small joints of the
it
hand.
mainly affects small muscles in the hand, and we see it in basal ganglion disorders and Huntington syndrome. Next, we have tremors, and this can be subdivided into essential, resting, and intentional. Essential tremor is highly
So we
focused.
already described this tremor, and now we go for some diseases where there is some abnormal movements. Wilson disease, it's a autosomal recessive disease, presents usually less than 40 years of age. We all know this disease is due to copper depositions in the liver, basal ganglia, and cornea. Due to involvement of the liver, patient may present with recurrent hepatitis or from acute hepatic failure even if due to involvement of the basal ganglia, the Wilson disease presentations is last like tremor. Patient may present with tremor, especially involving the shoulder joints, and this is called wing beating tremor. We will see this at tremor. Patient may present with dystonia as there is involvement of the basal ganglia. Patient may present with dysarthria and features of Parkinsonism in early years in the form of rigidity. Sometimes patient presents it with some psychiatric manifestations. These are neuropsychiatric manifestations of Wilson disease. And when this copper deposited in the cornea, that is called Kaiser-Fleischer ring, invariably in 90 to 95% cases of CNS involvement, KF ring is found. We all know it's actually autosomal recessive disease, and there is a mutations of the ATP7B gene, which is involved in the copper crossing the blood-brain barrier. So ATP7B gene is involved, is mutated in Wilson disease. This is the typical wing beating tumor and KF ring in a patient with Wilson disease. The tremor usually presents when the hands is at the level of the shoulder. Actually, this tremor is the shoulder joint, so this is called the wing beating tumor. This is the wing beating tumor. Tremor aggravated when the fingers are approximate at the nose level, that's at the level of the shoulder joints, but not at the other levels. This is a very typical of wing beating tumor in Wilson disease. The more marked at the level of the nose, that is when the shoulder, when the hand is above the level of the shoulder, there is stimulus movement. This is called wing beating tumor. And invariably, in case of Wilson neuropsychiatric manifestation, there should be involvement of the cornea in the form of KF ring. The best initial test for neuropsychiatric Wilson disease is KF ring by slit lamp examinations. We can go for serum ceruloplasmin, it is usually low. The most accurate diagnosis is 24 hours urinary copper level. Sometimes liver biopsy may be needed for confirmation, where there is increased parenchymal copper content in liver biopsy. And this is the greenish, this is the KF ring. This is a very pathognomic It can be seen in a naked eye also, but better should be seen in slit lamp examinations. And it's very pathognomic for neuropsychiatric manifestations of Wilson disease. Sometimes we can take help from MRI, some findings in MRI, special findings in MRI. This is called panda eye sign. There is enlargement of the red nucleus, red nucleus with surrounding hyperintensity, and the red nucleus is more hypointense and is more prominent in midbrain, and in the form of that's resembling as a panda's eyes. This is the pathognomic features of Wilson disease. Sometimes Wilson disease presented with this patient presented to me with neuropsychiatric manifestations of Wilson's, and there is a bilateral basal ganglion hyperintensity. In case of MRI, T1 hypointensity, T2 hyper, or flare hyperintensity, even T1 hyper, T2 hypointensity can also occur in case of Wilson disease. So, in case of Wilson disease, there may be panda sign in the midbrain. There may be hyperintensity in T2 and hypointensity in T1, or even hyperintensity in T1 and hypointensity in T2 occurs in case of Wilson disease. How will you manage the case of Wilson disease? There's some general management and there's some specific management. General management, we should offer him or her low copper diet. Avoid foods that such as shellfish, nuts, chocolate, mushroom, and organ meat. Any type of organ meat should be avoided. Hepatotoxic drugs, alcohol, and food that is high in copper should be avoided. And liver function test should be checked every 6 monthly. This is general management portion. For specific management, we should use copper chelating agents, either penicillamine or trientine. Trientine is better tolerated and is preferred over the penicillamine. And these chelating agents promotes urinary excretions of copper and also help the patients for depletions of this copper from his body. Zinc is not used initially for all cases. It is reserved for patients with asymptomatic Wilson's, pregnant patients and in pediatric population group, and patients with predominant neurological manifestations can be offered zinc sulfate as initially, but not in other case. It should not be used initially. For maintenance therapy, you can use either zinc or low dose chelating agents, but treatment should be lifelong. The treatment should be lifelong. Treatment for Wilson disease should be continued during the pregnancy, but dose reduction is advised for case of chelating agents. But this treatment should not be stopped for a single day. It should be continued. Sometimes liver transplantation can be offered in case of acute liver failure, in case of decompensated cirrhotic patients, or when patients are unresponsive to all types of drug, then we can offer liver transplantations, and patient may be free from Wilson disease. Another movement disorder, that is chorea. Chorea actually derived from the Greek word jopia. Jopia means dance, and this choreoform movement is just like dancing movement. কোরিয়াফর্ম মুভমেন্টের আমরা ফেনোমোলজিকে আমরা 4টা ক্যাটাগরিতে ভাগ করি। নাম্বার 1, এটা হবে র্যান্ডমলি। ইট শুড বি র্যান্ডমলি। ইট শুড বি ফ্লোয়িং। দ্যাট মিনস ইট স্টার্টেড ফ্রম ওয়ান পার্ট, then it traverses the other part of the body, that is flowing in nature. Phenomenology, number 1 criteria of chorea, it should be random. It should be random and it should be flowing quality. There should be some motor impersistence. Motor impersistence means patient cannot do কোনো একটা স্পেসিফিক মুভমেন্ট সে লং টাইম ধরে পারবে না। যদি সে টাংটাকে আমি প্রোটিউট করতে বলি, সে কিছুক্ষণ পরে টাংটাকে প্রোটিউট করতে পারবে না, ভিতরে ব্যাক করবে। আমি তাকে যদি হ্যান্ড শেক করি, ইফ আই ডু হ্যান্ড শেক উইথ দিস পেশেন্ট, হি উইল স্কুইজ মাই হ্যান্ড। দিস ইজ কল্ড motor impersistence. This is also another features of chorea. How can we evaluate a choreiform patients to know the underlying cause. If there is involvement in the forehead, it is should be Huntington disease. If the orobacolingual region is involved, it may be tardive chorea or acquired hepatocellular degenerations, some inherited disease, chorea acanthocytosis, Lesch-Nyhan syndrome, Pecan. These are the uncommon type of inherited diseases that can cause also chorea. And when the chorea is present on sides of the body, that is hemichorea, there should you should search for either any structural lesions on the contralateral side of the basal ganglia, maybe non-ketotic hyperglycemic coma. I have found recently 4 cases of non-ketotic hyperglycemic state where there is patient present with hemichorea. Polycythemia rubra vera can present with hemichorea. Sydenham chorea sometimes presents with hemichorea, but it may present with bilateral chorea. These are the most common cause of hemichorea. This is my patients presents with hemichorea with some breathing movement as chorea and athletic movement on the left side. Uh, and I did a CT scan of brain, and there is a hyperdense lesion, that is a humerus in the right basal ganglionic region. And patient presented to me with sudden onsets of left-sided hemichorea with hemi with athetotic movement. This patient presented to me with also hemichorea, and patient had high diabetes mellitus and so this is a hemichorea with some hemibellismus also. There is a flinging movement, hemibellismus also. This is a random flowing movement, and also there's some motor impersistence. The prototype of chorea is the Huntington disease. You all know it's a autosomal dominant disease with trinucleated repeat expansion of CAG. And we know when there is a trinucleotide repeat expansion, there should be anticipation. That means the next generation will develop this disease earlier age than the previous generations. This is called anticipation, and it is very common in trinucleotide repeat expansion. Patient usually presented with dementia or personality disorder and at the age of 40 to 50 years. Maybe some associated depression and sometimes suicidal tendency or even suicide in 5 to 8% of cases. Patients usually presented with chorea, but in later stage, patient presented with dystonia and seemingly like Parkinson disease. And at the same time, patient has motor impersistence, that is আমরা যেটাকে বলি যে jack in the box sign, that is a difficulty in holding his tongue. This is called jack in the box sign, and hand grip sign by milkmaid sign is there. This is due to motor impersistence. And this is a patient presented to me this type of choreiform movement associated with some jack in the box. There is a motor impersistence. Here's some chorioathetotic movement bilaterally. You can see some abnormal movements on both upper limbs and also both lower limbs also. This is a patient presented at his 40 years of his age. Now he is 44 years. For last 4 years he has been suffering. Still there is no dystonia but some choreiform movement. This is motor impersistence, Gibbata. He cannot hold his tongue for long time. This is called Jack in the Box sign. We can take help from CT scan or MRI. At the same time, we can go for Huntington genetic study. In CT scan, there is as a whole gross atrophy of the brain. At the same time, the caudate nucleus is atrophied. For this region, the frontal horn is enlarged. This is a normal frontal horn, and this is the caudate nucleus. But now here it is there is fullness of the frontal horn, and there is atrophy of the caudate nucleus head. But there is a gap here, but there is no gap here. It is full. It is a very pathognomic of Huntington disease or Huntington chorea. So we can take help from CT scan to diagnose this chorea, but confirmatory diagnosis is genetic study for Huntington disease. Treatment: the drugs used for choreiform movement and for the Huntington disease, the only one drug is available. There is tetrabenazine. Tetrabenazine actually is a dopamine depletion drugs that decrease uptake of dopamine into the synaptic vesicles. আমরা যদি দেখি যে this is the dopamine and this is the vesicles. This is called vesicular monoamine transporter VMATs, and these dopamine are engulfed into these protein vesicles and then released into the synapse, and this tetrabenazine inhibits these bindings of these VMATs with this dopamine. So less dopamine in the synaptic vesicles, and there will be less movement. Another movement disorder is the tics disorder. The prototype is Torrid syndrome. টিক্স অ্যাকচুয়ালি আমরা এটাকে অনেকে বলি মুদ্রাদোষ টাইপের, যে অনেকের একটা স্পেশাল পার্ট অফ দ্য মুভমেন্ট হয়, বাট হি অর শি ক্যান কন্ট্রোল বাই মোরাললেস কিছুটা কন্ট্রোল করতে পারে, এরকম কিছু মুভমেন্ট হয়, এটাকে আমরা টিক্স বলি। and the prototype is a Torrid syndrome, usually started in 5 to 7 years of age. In case of Torrid syndrome, there should be multiple motor tics. There may be vocal tics, some abnormal sound, অনেক সময় দেখা যায় অনেকে গলা খাক্কার দেয়, that's also a vocal tics. তবে if these types of movement is started after 21 years, it unlike the Torrid syndrome, and these types of tics should be present for more than 1 year, and male is more affected than the female, but 50% of the patients will resolve by the age of 18 years. টরেট সিন্ড্রোমের সাথে সব অ্যাসোসিয়েটেড ফিচার থাকে, যেমন এডিএইচডি থাকতে পারে ইন 60% কেসেস, ওসিডি থাকতে পারে অবসেসিভ কম্পালসিভ ডিসঅর্ডার ইন 30% অফ কেসেস, অ্যান্ড টরেটস ইউজুয়ালি আমরা এটাকে বলি বাইলিনিয়াল ট্রান্সমিশন। এখানে বোথ মাদার অ্যান্ড ফাদার শুড বি অ্যাফেক্টেড, অ্যান্ড বোথ মাদার এবং ফাদার থেকেই দুইটা যখন একসাথে জিনটা আসবে তখনই কেবল ডিজিজটা প্রোডাকশন হয়, এটাকে বলে বাইলিনিয়াল ট্রান্সমিশন। And it is treated with dopamine blockers like haloperidol or other antipsychotic drugs, and sometimes botulinum toxins is very effectful in case of Torrid syndrome. We will watch a video on Torrid syndrome, tics and other Torrid syndrome.
Tics are repetitive, involuntary movements, and they can be split into two groups. So one is vocal tics, and so that's phonic sound, and often simple. That could be something type is called motor tics. And motor tics are often kind of bursts of movement. So that could be something like a nose scrunch or an arm movement or even a head tilt. Those are a series of movements. So those often look more purposeful in nature. That could be something like a twirl or a jump or something that even looks like a dance movement. And then there's complex vocal tics as well. And that's like saying a series of words or sentences, but often they don't fit into what the child is talking about. Probably the most famous tic disorder is Tourette. Tourette was discovered by Georges de la Tourette, who named it after himself in 1884. And Tourette's, you have to have multiple motor movements and one vocal tic over the course of more than 1 year. To have a diagnosis of something like a tic disorder or Tourette's, a lot of times that's become functionally impaired. So what that means is that gets in the way of me thinking, that gets in the way of me talking to others. The other difference between just kind of having a movement and something like a tic or Tourette is something called premonitory urge. And so that's kind of like a feeling of itching or burning, or I just got to do this thing for everything to be all right. We know that tics run in families, so that means that there's a genetic contribution to that, similar to hair color or eye color or height. We also know that there might be situations in our environment that increase our tic behavior. So that could be experiencing stress or having something like a diagnosis of anxiety. They're often diagnosed with other mental health diagnoses like OCD, ADHD, anxiety, and learning disorders. The medication most oftenly prescribed for kids with tic disorders are often in the atypical antipsychotic, analeptic, or alpha-2 agonist family. One of the treatments that we have here at Akron Children's Hospital is something called Comprehensive Behavioral Intervention for Tics, or CBIT for short. And so CBIT is a short-term therapy. It's usually 8 sessions over the course of 10 weeks, and it's often with parents involved as well. And so the first part of this therapy is we try to figure out what that premonitory urge looks like for that child. So what do they experience prior to the tics? We also spend a lot of time thinking about what's going on in their environment when they're ticking more. So are these kids that are having tics more in class? Are these kids?
This is the patients of a Torrid syndrome.
This boy demonstrates frequent blinking, which is associated with alternating facial contractions, tongue protrusions, and mouth openings, typical of Torrid syndrome.
Neuroleptic malignant syndrome and serotonin syndrome is very important. Sometimes patients presented with us some features of encephalopathy with agitations, muscular rigidity, tremulousness, autonomic nervous system instability causing fever, and these patients maybe gives history of taking haloperidol, metoclopramide, prochlorperazine, and this is called neuroleptic malignant syndromes. There is dysfunctions of both basal ganglia and hypothalamus. It is diagnosed clinically, and also is raised CPK level, and it is treated by supportive treatment, stopping all the offending agents. Dantrolene is a very effective drug that blocks the calcium release from the sarcoplasmic reticulum, and there causes muscle relaxations. Bromocriptine is a drug, is a dopamine agonistic drug. It is not used in Parkinson disease, but it is used in case of neuroleptic malignant syndromes. Sometimes amantadine is also drugs for Parkinson disease, also help in neuroleptic malignant syndrome. The closely clinical presentation is serotonin syndromes, and it is due to there is increased release of serotonin from cocaine, ecstasy, Use of SSRI, that is citalopram, fluoxetine, sertraline, duloxetine, venlafaxine, meperidine, or even tramadol. These drugs can cause serotonin syndrome. Serotonin syndrome. Patients may present with features of encephalopathy, that is altered level of consciousness, headache, convulsions, severe agitations, autonomic hyperactivity, resulting in tachycardia, increased sweating, fever, even hypertension, malignant hypertensions, neuromuscular hyperactivity resulting in tremor, rigidity, even myoclonus. On examinations, patients have all the reflexes may be increased, plantar may be bilaterally extensor, and there may be clonus. These are the features of serotonin syndrome when there is a previous history of this type of drug intake. How will you treat it? Treatment is supportive treatment, stop the offending of medications, and here choice of drug is benzodiazepines. Sometimes cyproheptadine is used, which is a serotonin antagonist, can be used in case of serotonin syndrome. How can you differentiate neuroleptic malignant syndrome from serotonin syndromes? Upper motor neuron findings on exams in NMS, faster onset of symptoms and faster resolution of symptoms treated. The patient is on serotonergic medications listed above. যদি পেশেন্ট এরকম হিস্ট্রি থাকে আগে থেকে তাহলে সেক্ষেত্রে আমরা পাবো পেশেন্টের। আর যদি পেশেন্টের সিমটমটা খুব র্যাপিডলি আসে এবং র্যাপিডলি রিজলিউশন করে তার আমরা বলতে পারবো সেরোটোনিন সিনড্রোম। এবং যদি পেশেন্ট আমরা প্লান্টার এক্সটেন্সর পাই, অল জাগস এক্সার্টেড পাই, তাহলে আমরা বলতে পারি ইটস ডিউ টু serotonin syndrome. And so we conclude our hyperkinetic disorder. Now we will proceed to hypokinetic disorder. So we can take a break of 2 to 3 minutes, then we will start our hypokinetic disorder. That is the most important topics, a most important disease of movement disorder, that is Parkinson disease and Parkinson plus. We can just take 2 to 3 minutes break. So we can again go for the most common hypokinetic disorder, the prototype, the Parkinson disease. We discussed previously the pathophysiology of Parkinson disease. Clinically, আমরা Parkinson disease কে diagnosis করি TRAP, TRAP, T for tremor. The initial symptoms in 50 to 70% of cases. The tremor is usually resting tremor and pill rolling movement is there. And the tremor frequency is 4 to 5 hertz. It started asymmetrically from the beginning. and at a late stage it becomes asymmetrical. The most specific features R for rigidity, it may be cogwheel rigidity or leg pipe rigidity. A for akinesia, bradykinesia, there is slowness or poverty of movement. Fine motor tasks are hampered like micrographia, there is small লেখাগুলো ছোট হতে থাকবে. There is problems in doing teeth brushing, buttoning, and is usually asymmetrical. There may be hypophonia, the voice may be low, and step size, there is small step. These all are the features of bradykinesia. TRAP, P for posture instability. It's a late manifestation of PD. Patients sometimes give history of fall, freezing, fascinating and shuffling gait, to posture, and asymmetrical less arm swinging. These all are the features of postural instability, and these are the late features of Parkinson's disease. Not only this cardinal feature, but also there's some other feature also in associated with Parkinson's disease. 40 to 50% patient may present with depression and anxiety, but not the presenting manifestations. 20 to 30% presents with dementia, but not so early. Sometimes patient presented with dyskinesia, especially if patient have been taking drugs, especially levodopa. Constipation is a very common symptoms associated with PD. Seborrheic dermatitis. Sometimes patient presented with dystonia, hyposmia. There is loss of smell, and as the Parkinson disease is a alpha synucleinopathy, and there is a REM sleep disorder, behavior disorder. There's some atypical features of Parkinson disease. There's some red flag sign. যদি এই রেড ফ্ল্যাগ সাইনগুলো যখন থাকে তখন আমরা বলতে পারি দ্য পার্কিনসন ডিজিজ ইজ আনলাইকলি। যদি পেশেন্টের আর্লি ডিমেনশিয়া ডেভেলপ করে, সো ইট আনলাইকলি অফ পিডি, ইট মোস্ট লাইকলি লিউ বডি ডিমেনশিয়া। If the autonomic disturbance occurs very early, it is multiple systemic atrophy. If patient present with frequent fall and gaze palsy with axial rigidity and also cerebellar sign, it is due to PSP or MSA. If patients presented with hallucinations in early stage, it is until others prove it is due Lewy body dementia. Other neurological examination findings, if not abnormal, like eye movement abnormality, ataxia, then we should go for either it is PSP, that is progressive supranuclear palsy, or multiple systemic atrophy, and lack of response to dopamine. We can say that is in case of Parkinson's disease, there is a honeymoon period of dopamine. In early 5 years, 7 years, even 10 years, patient responds very well with dopamine drug. If the response to dopamine is less, it is unlikely of Parkinson's disease. Most likely is either secondary Parkinsonism or any Parkinson plus or any otherwise. The pathophysiology of Parkinson's disease is there is a this is a normal midbrain histopathological structure, biopsy structure. There is a hypopigmentations of the substation nigra. In case of Parkinson's disease, the pigmentation is decreased, and there is presence of Lewy bodies. These are the Lewy bodies. These are the pathognomic features of Parkinson's disease. Parkinson's disease patient usually presented with resting tremor and sometimes postural tremor and sometimes re-emergent tremor. Re-emergent tremor is very pathognomic of Parkinson's disease. Re-emergent tremor is that type of tremor when the patient's tremor is present at the rest, but when he যখন সে কোনো একটা কিছু ধরতে যাবে ট্রেমরটা প্রথমে কম থাকবে, কিন্তু যখন সে কাছাকাছি চলে আসবে তখন ট্রেমরটা বেড়ে যাবে। এটাকে বলে আমরা রি-ইমার্জেন্ট ট্রেমর, and this re-emergent tremor is very much pathognomic of Parkinson's disease. Parkinson's diseaseর ক্লাসিফিকেশন আমরা করি স্টেজিং করি। স্টেজ 1 যখন শুধুমাত্র ইউনিলেটারি ইনভলভমেন্ট, মিনিমাম আর নো ফাংশন ইম্পেয়ারমেন্ট, তখন তাকে বলি আমরা হোয়েন অ্যান্ড ইয়ার স্টেজ 1। স্টেজ 2 যখন বায়োল্যাটারাল অর মিডলাইন ইনভলভমেন্ট উইদাউট ইম্পেয়ারমেন্ট অফ ব্যালেন্স, তখন সেটাকে আমরা স্টেজ 2 বলবো। Stage 3 হচ্ছে ফার্স্ট সাইন অফ ইম্পেয়ার রাইটিং রিফ্লেক্স এন্ড মাইল্ড টু মডারেট ডিসএবিলিটি। যদি মাইল্ড টু মডারেট ডিসএবিলিটি থাকে এবং পোস্টাল ডিস্টারবেন্স থাকে তখন সেটাকে বলবো আমরা স্টেজ 3। fully developed severely disabling disease, patient is still able to walk and stand unassisted, তখন সেটাকে বলবো আমরা স্টেজ 4। আর যখন পেশেন্ট কমপ্লিটলি কনফাইনমেন্ট টু দ্য বেড or wheelchair, it is called stage 5. So it is the staging is helpful for prognostic purpose. There are lots of drugs available for Parkinson disease, and we all know levodopa is metabolized to dopamine by the dopa decarboxylase. Dopamine is metabolized to 3,4-dihydroxyphenylacetic acid by monoamine oxidase, and catechol-O-methyl transferase to 3-O-methyl dopa. So our target is to increase the dopamine. It may be in the form of dopamine, maybe in the form of dopamine agonist, and maybe some drugs that affect different enzymes that degrades the dopamine. And another group of drugs is anticholinergic drugs like benztropine, procyclidine, trihexyphenidyl can also be used. The first choice of drug and the mainstay of treatment of Parkinson disease is levodopa. But levodopa is added with carbidopa. Why carbidopa? কারণ লিভোডোপা যখন পেরিফেরিতে থাকবে, সেই পেরিফেরিতে থাকার সময় লিভোডোপাটা মেটাবলিজম হয়ে যেতে পারে ডোপা ডিকার্বোলিজ দিয়ে। Carbidopa inhibits these metabolisms and this can send it to the brain, but this carbidopa does not cross the blood-brain barrier and it retains in the blood, and the levodopa goes into the brain and then it metabolized to its dopamine. So carbidopa is used to inhibit peripheral decarboxylations. আমরা এটা আগে বলছি যে পেশেন্টের যদি আমাদের লিভোডোপা রেসপন্সিভ ভালো না হয়, আমাদের সেক্ষেত্রে ডায়াগনোসিসটা আমাদেরকে মাথায় রাখতে হবে, ডায়াগনোসিস আদারওয়াইজ কিনা। Side effect, what are the side effects of levodopa? Patient may present with nausea or vomiting, and it is sometimes you can use domperidone. Patient may present with hallucinations, and the most common side effects and most dreadful side effects is dyskinesia. If patients present with early age, that is less than 65 years, and progressive symptoms, we should use dopamine agonist. The drugs used as dopamine agonist is either pramipexole and ropinirole. So younger as a patient আসলে আমাদের ফার্স্ট চয়েস থাকবে আমরা ডোপামিন অ্যাগোনিস্টিক ড্রাগ দিব। যদি ওল্ডার এজ থাকে সেক্ষেত্রে আমরা ডোপামিন ড্রাগ দিব, বাট ইয়াঙ্গার এজ আসলে আমরা আইদার প্রামিপেক্সল অথবা রোপিনিরল আমরা অ্যাড করব। প্রামিপেক্সল অথবা রোপিনিরল হচ্ছে ইটস এ অ্যাগোনিস্ট এট D2 and D3 but little actions on D1. It's very effective drug in young age, but it can cause nausea, hallucination just like dopamine. It can also cause confusions and impulse convulsive disorder, that is called gambling, pornography, eating disorder, even sexual dysfunction. This effect is not occurred in levodopa, but this side effects occurs in dopamine agonistic drug. Sometimes patients present with sudden attacks of sleep by this ropinirole. Dyskinesia is very less common in case of dopamine agonistic drug, but more common in dopamine, levodopa, carbidopa. Anticholinergic drugs are not used very commonly in Parkinson disease in older age group, as these drugs are very much these drugs potentiates the cognitive impairment and patient may complain of dementia. So as older age পেশেন্টের এমনি ডিমেনশিয়া থাকে আর পার্কিনসন ডিজিজের পেশেন্টের ডিমেনশিয়া থাকে, সো এদেরকে আমরা অ্যান্টিকোলিনারিক ড্রাগ দিলে তাদের ডিমেনশিয়া ডেভেলপ করতে পারে। এই কারণে আমরা ইউজুয়ালি ফার্স্ট লাইন ড্রাগ হিসেবে কখনো অ্যান্টিকোলিনারিক ড্রাগ ইউজ করি না। তবে ট্রেমর প্রিডমিনেন্টলি ইয়াং এজে যদি পেশেন্টের থাকে সেক্ষেত্রে আমরা অ্যান্টিকোলিনারিক ড্রাগ দিতে পারি, যেমন আইদার ট্রাইহেক্সাফেনাডিল অথবা বেনস্ট্রপিন। Another drugs is MAO-V inhibitors, that is rasagiline and selagilin. Rasagiline is still used. Once upon a time, it was thought that the rasagiline is a neuroprotective drug, but nowadays it is thought that no, it has no neuroprotective role. নতুন যত গবেষণা হচ্ছে সব ট্রাই করা হচ্ছে যে কোন ধরনের কোন নিউরোপ্রোটেক্টিভ কোন ড্রাগ আছে আসতেছে থাকতে পারে কিনা, অথবা এনি ডিজিজ মডিফাইং কোন এজেন্ট আছে কিনা। So rasagiline was thought once upon a time is a neuroprotective drugs, but not nowadays. It's a neuroprotective agents, but it is helpful as a add-on therapy. কখনো আমরা রাসাজিলিনকে সিঙ্গেল এজেন্ট হিসেবে ইউজ করব না। যখন ডোপামিন দিব, ডোপামিনের সাথে আমরা রাসাজিলিন ইউজ করতে পারি, যাতে ডোপামিনটা লং টাইম আমাদের বডিতে থাকতে পারে। কারণ মাও বি কি করে, এটা ডোপামিনকে মেটাবোলাইজ করে, সেটাকে প্রিভেন্ট করবে। সো ডোপামিনটা লং টাইম সিনাপসে থাকতে পারবে। Another drug is a amantadine, is the antiviral agents. এটা ডিফারেন্ট মেকানিজমে অ্যাকশন হয়, তবে এটা কখনো ফার্স্ট লাইন ড্রাগ হিসাবে আমরা ইউজ করি না, কারণ এর বেনিফিট ইজ মাইল্ড, বাট ইট ইজ ভেরি ইফেক্টফুল ইন কেস অফ dopa induced dyskinesia. When a patient presents with Parkinson disease with dopa induced dyskinesia, amantadine may be used to control this dyskinesia. COMT also as an add-on therapy, it can also cause prolong the effects of the levodopa, and it can be effectful in wearing off effect, and they should be used along with levodopa. And recent advancements of Parkinson disease management is deep brain stimulations. Deep brain stimulations. It's a minimally invasive surgery, just like pacemaker of the heart, where a probe is inserted into the subthalamic nucleus and also globus pars interna, and it is controlled externally. Both neurosurgeon, especially functional neurosurgeon, and a neurologist is required. The best candidates of DBS are, you have the patient had PD symptoms for last at least 5 years. Patients may have on and off fluctuations with or without dyskinesia. Patients have well controlled with medications. If patients not responded with medications, the DBS is not fruitful. If patients was controlled with drugs initially, but after 5 years the control is not well, then you can offer him DBS. When lots of drugs are failed by different combinations, you can offer DBS. If the PD symptoms hampers daily activities despite taking lots of drugs, then you can offer him DBS. There are some complications of DBS like death, stroke-like symptoms. There may be problems with mood disorder, memory impairment, thinking capability, even convulsions or infections of the ইনফেকশন হতে পারে, যে সমস্ত সাইড দিয়ে এটা প্রবটা ঢোকানো হয় ওখান থেকে ইনফেকশন হতে পারে। সো ডিবিএস ইজ নট এ ভেরি ইজি সার্জারি অ্যান্ড নট, এটা অনেক এক্সপেন্সিভ সার্জারি। আমাদের দেশে এখন বছরে একবার হয়, বাইরে থেকে আসে, বাট ইটস ভেরি ইফেক্টফুল if patients presents with uncontrollable Parkinson disease or Parkinson disease with dyskinesia, but patient respond very well with drugs initially, but now it is not responding, we can offer him DBS. If a patient suffering from PD but he needs some antipsychotic medications, which drug you will offer? We will offer quetiapine, as it's a least causes of Parkinsonism, quetiapine. Another drugs can be used, that is clozapine, but clozapine has a side effects of severe neutropenia, so we commonly use quetiapine. If a PD patient associated with some psychiatric manifestation, we can use quetiapine. Progressive supranuclear palsy is a Parkinson plus, where there is early falling, there is axial rigidity, there is a gaze palsy, and there is a problems during down gaze on mainly, and poor response to the medications with associated pseudobulbar palsy. And the important signs of PSP is called hummingbird sign. There is a atrophy of the midbrain and seems like a hummingbird, seems like a hummingbird. এটাকে বলে আমরা PSP একটা hummingbird sign due to atrophy of the midbrain. And this is a patient presented to me with features of Parkinsonism, but early development of his gaze impairment and also axial rigidity, and ultimately diagnosed as PSP. He has also a hummingbird sign in his MRI. Patient cannot move his eyes. At the patient presents at advanced stage, he could not move his eyes upwards and downwards on any sides. It's complete ophthalmoplegic, complete gaze palsy. But initially in PSP, there is downward gaze palsy. Multiple systemic atrophy is another type of Parkinsonism, Parkinson plus. Age of onset usually 54 years. Previously, it was termed as Shy-Drager syndrome, but it is not now used as a. As there is also some other features, so it is better used as multiple systemic atrophy. 80% poorly responsive Parkinsonisms, 20% with progressive ataxia and Parkinsonisms. When we suspect a Parkinsonism as MSA, there is early falling, rapid progression, poor response to therapy, autonomic disturbance at early onsets, pseudobulbar palsy, and REM sleep disorder. As MSC is also a synucleinopathy, so there should be REM sleep behavior disorder. That patient does like acting of his dreams. And MRI is a very pathognomic features in case of MSA. This is called hot cross band sign. There is a crossing hyperintensity divide the pons into চারটা ভাগে ভাগ করে দেয়, অনেকে দেখতে মানে এটা বান সাইনের মতো, হট ক্রস বান সাইন বলে এটাকে। There are also some causes of Parkinsonisms like drugs, like dopamine blocking agents, like antipsychotics, antiemetics, metoclopramide. These all can cause secondary Parkinsonisms. Some other diseases like post-encephalitis, it can also cause Parkinsonism, secondary Parkinsonism. Recurrent stroke can also cause vascular Parkinsonism, also is a secondary Parkinsonism. So that's all from today. Thank you very much. It's a long time.